afternoon, everyone, and welcome in Jeddah. I will be presenting some thoughts about endovascular approaches in chronic mesenteric ischemia. I get no disclosures regarding this presentation. So, chronic mesenteric ischemia is a rare condition and described first at the 1918 by Goodman, and the etiology mostly due to atherosclerosis. There are other reasons that might be causing that. The presence of mesenteric artery occlusive disease, though, is relatively common and has been found by Wilson et al. That when he studied 500 patients, he found the presence is about 17% of those patients has got a significant occlusive disease on one of the mesenteric vessels. However, those who have experienced chronic mesenteric ischemia as only representing 1 in 1,000 hospital admissions with abdominal pain. And this will be due to the predominance of the arcades in the abdomen and collaterals that really compensate in those cases. And because there is no reliable functional test that diagnoses those patients, we really rely on the clinical scenario of the patient and the presence of disease and the imaging. And interventional modalities will be either open bypass using synthetic or veins, and in antegrade or retrograde fashion. Could be done as well with endovascular techniques using antegrade or retrograde using perimetal stents or cover stents. Could be also performed in a hybrid way where doing a retrograde open mesenteric stenting. So the first case I'm going to present is an 82-year-old gentleman who is diabetic, hypertensive, and ischemic heart disease, and referred to our institute with a weight loss, not tolerating food for a long time, and he was on fluids for the past 6 months before his presentation to us. He was lethargic with a very low PMI of 16, and investigation showed no pathology present in the upper and lower GI. CT-NG showed significant stenosis at the celiac artery with occlusion at the SMA. So because the patient was generally depleted and we started him on partial parenteral nutrition for 2 weeks when he was okay to go for the procedure, we took him straight away for the SMA percutaneous stenting using left brachial artery access. That was the result afterward. And he was recovered very well, started tolerating food right from the next day of procedure, and the stent was patent in the first and second year of presentation. The second case is a 77-year-old lady. She's comorbid, diabetic, hypertensive, and ischemic heart disease. And she presented to ER with a history of gradual progression of abdominal pain over the past 4 months associated with weight loss. And the abdominal pain is diffuse and becoming really unbearable on daily basis. Investigation was negative for any non-vascular pathology, and the CT-NG showed only 50% stenosis of the celiac artery with total occlusion of the origin of SMA. The patient underwent a trial of endovascular revascularization, but failed to cannulate the SMA origin as it was flush occlusion. So we did angioplasty and stenting of celiac artery, hoping that it might get her symptoms a bit better. Postoperatively assist for a few days, but apparently there was no improvement in her symptoms. So we sat with the patient and her family and give them the risk and benefits of the consequence management, and the decision was to do the intervention by open technique. And due to her comorbidities, we just tried to give a trial of retrograde open mesenteric stenting before doing and attempting the bypass for her. So that was the laparotomy. We accessed the SMA distal in a retrograde fashion. We passed to the aorta. It was easy. And stenting with a perimetal stent, and then closure of the arteriotomy with a figure of 8 and closure of mesentery. Patient improved dramatically afterward, and her CT angio 1 year after the procedure. The procedure took only about 15 minutes intervention if we took off the laparotomy and the closure. So looking at the chronic mesenteric ischemia clinical practice guidelines published by the Society of Vascular Surgeons at the Journal of Vascular Surgery in 2021, we just get some highlights of some points. So they mentioned that asymptomatic patients with even severe mesenteric disease needs to be followed up on regular basis without any intervention. That was grade 1 recommendation. And endovascular revascularization is the initial treatment for patients with CMI with suitable lesions. And it was the grade 1 recommendation. And they recommended that reserving the open surgical revascularization for patients whom CMI was not amenable for endovascular therapy or for young patients. And I think this will get changed in the near future. The last point I will highlight is the balloon expandable covered stent is the stent of choice with mesenteric artery occlusion disease and CMI with the level of recommendation grade 2, which means it is negotiable. From the last point, we just highlight a recent randomized control trial published this year at the Lancet, and looking at both covered and bare metal stents, you can see clearly that the primary patency is significantly better in the covered stents than the bare metal. And the other way around, the procedure-related adverse events was 36 patients whom covered stent were deployed in them compared to 19% of bare metal stents. And 80% of those complications were related to access complication. This is a trial that's going on at the moment, still in the recruitment, finished recruitment 2025, and it is addressing the same concern. So my conclusion, ladies and gentlemen, is CMI is a rare disease. Management needs to be planned very well and handled differently than peripheral vascular disease. Moving towards endovascular first for all candidates, even low-risk group, will be the standard of care. Covered stent will be the first choice option only when feasible. And we need to have a low threshold to perform access cut down to minimize access-related complications, and also to follow up is mandatory for those patients to maintain the secondary patency and get the best outcome in these procedures. Thank you so much.